set up a spin-out company to commercialize some of this, but that's not what I'm talking about today. The work that has been done since the company was set up is not being discussed today. So the learning objectives, and that's a bit hard for me to say from here, but by the end of the lecture, the attendee should have a greater knowledge of the limitations of semen analysis, the pros and cons of sperm DNA fragmentation tests, the relationships between sperm DNA damage and ART outcomes, the hypotheses as to why sperm DNA does not influence ICSI outcomes, although it does IUI and IVF, the mechanisms of DNA damage, although I think we've already covered that in the last lecture very beautifully, and the benefits and risks, where again I'm going to take up what Professor Slat was talking about there in terms of can we overdo on antioxidant supplements, and then some of the proxy tests that there are for DNA damage. Sorry, can you hear me okay? Yeah? Because of course there are limitations with DNA damage tests as well. So I know we started talking about semen analysis, and of course semen analysis is the gold standard, and semen analysis is the test that is recommended by NICE in the UK, and it's also it's in the WHO recommendations. But I would agree entirely with Rebecca that one thing that semen analysis does tell us is how many sperm you have. Have you got enough sperm to do some ART? But really it doesn't tell you an awful lot more than that. It has limited diagnostic value for both male infertility and also for its prognostic value for ART outcomes, even the very early outcomes. If we look at semen analysis in donor sperm compared to that of patients, you can see here that really, whether you're talking about concentration, morphology or motility, there's very little relationship and that separates the donors from the men who are attending for infertility investigations, and there's a very high overlap between the two. On the other hand, there's very little relationship between sperm DNA damage and semen analysis parameters. And of course that's exactly what we would hope, because there's no point in adding an adjunct of DNA testing to a semen analysis if it gives you exactly the same results as you can get without it. And the only relationship that we found using the COMET test was a relationship between sperm motility and DNA damage. And that was what we would expect, because motility is a real-time indication of whether the sperm is alive or healthy. Concentration doesn't matter to some extent, morphology doesn't matter so much, but if the sperm is swimming vigorously, you know that that's a healthy sperm. And so we found a relationship between DNA damage and progressive motility. But if you look at the odds ratios in terms of which one was the better prognostic test for fertilization in vitro, you can see that the DNA test is much higher, the odds ratios are much higher than those for motility. If semen analysis isn't particularly good, then if we turn to sperm DNA anomalies, we can see that they actually influence every fertility outcome that we have, from poor embryo development to failure of fertilization in IVF, not of course in ICSI, because that's a rather artificial figure, because the embryologist basically puts the sperm inside the egg. A failure to implant in ICSI and post-implantation loss and malformations from animal studies. Increased miscarriage is associated with high DNA damage. I'll talk a little bit more about that later. And childhood health. And I think that's where we're moving to now. Again, that was very interesting what Rebecca was talking about in terms of the outcomes to different specialties are very different. But the outcome that society wants is a healthy child. And as the number of conceptions from ART increase around Europe, and as birth rates drop from spontaneous conception, and so the children who are born as a result of ART become a larger proportion of the population, then it's really important that we're producing healthy children as well as just success within the lab. So in terms of detecting sperm DNA damage, there are 4 tests that are the most popular ones that people use. There's the COMET test, which we've used in Belfast for a long time. There's the sperm chromatin structure assay, which is the daddy of them all. It's been around since 1980. There's the tunnel assay. And then there's the halo test, which isn't really a DNA fragmentation test. It's more a test to tell you whether the chromatin packaging is adequate or not. So if we look at the tunnel At the moment, we don't really have a clinical threshold for the tunnel, and one of the problems is that the tunnel is done very differently in every lab around the world that uses it. Now, a couple of years ago, all of us working on DNA got together in Florence and said that we would really like to take the same semen sample, aliquot it out, send it to all of the labs that were interested in doing it, and do a comparison. First of all, to see how the tunnel compared to the SCASA compared to the COMET, and also to see what the reproducibility of these tests were within the different labs. Alas, that didn't happen. We're now trying to resurrect the idea and do it again, and I would be very keen that we would do this, because we'd have a much better idea then on how useful the tests are. The HALO test, as I was saying, is really the opposite of all the other tests in that this is a normal sperm, because you get this relaxation of the chromatin and the proteins around the nuclear head. And the one here which didn't create a halo is the one which is abnormal. Now, when you get you're looking for the absence of something, it's very difficult to know how accurate that is, because if you're looking for the absence of something, it may be to do with your protocol that you didn't actually do it properly. Also, in terms of the actual results for the halo is very popular because it's something that can be used in a lab. The other tests really have to be outsourced because they're much more complicated, and certainly your routine IVF lab is not going to be able to do a SCASA or a COMET test. But in terms of the HALO test, yes, lots of people have taken it on board because they can do it within their semen analysis, basically within a lab. But here's one of the biggest studies which was done, and this shows that really there's no relationship between the HALO and either pregnancy rates or live births. Here's another study which came out more recently, and again this shows first of all, that there is a relationship between DNA damage with the halo and semen parameters, which is again what we don't really want, because that just gives us a confirmation of what we had before. And secondly, it doesn't show much of a difference between the pregnancy rates, or the people who had DNA damage and got pregnant, and the people who had DNA damage and didn't get pregnant. The SCASA test, as I was saying, is the daddy of them all. This was developed by Don Evenson many, many years ago. It's a robust test. It has many, many studies confirming it. And it's one that needs to be outsourced, so you can send samples off to SCASA Diagnostics and they can give you a result within a pretty short time. This is some of the results from the SCASA test, and here you can see that there is a strong relationship between IVF success in terms of pregnancies and also live births and low DNA damage. That's not the case for ICSI. So DNA tests work well for IVF to predict it. They don't work so well for ICSI, and I'll talk about that in a moment. The sperm COMET assay is a different type of test in that all the other tests give you an all or nothing result. So if you put 100 cells, 100 sperm through a flow cytometer or whatever way you measure it, and you get a result of 30%, that means that DNA damage was detected in 30% of the sperm and 70% it wasn't detected. Because it's an all or nothing, it's usually a colour change. That's not the case in the sperm COMET test, because what we do there is we actually lyse the membranes, relax the DNA, and because the DNA is charged, if you put it into an electric field, then depending on the fragment breaks, they will pull out into what is like a comet tail. So that's why it's called a comet. It's just like a celestial comet. And from the length, then you can measure the amount of damage per sperm, which is different to the other tests which show you the damage per sample. Some of the criticisms of the COMET have been that it only uses a small number of cells, whereas the others use many cells. We've done tests in our lab to show that it is an adequate number of cells, and even if you double the number of cells or triple the number of cells, you still get the same results, so it is a robust test. In terms of establishing clinical thresholds, again, we've done some work on this. This was first of all to attending for infertility investigations, and we had fertile donors from a sperm bank. And we found that this sort of cut-off point of about 25%, 95% of the donors fell below this, but only 7% of the men attending for infertility investigations. And again, below you can see the sensitivity, specificity, and the predictive values here, and the ROC. So they're quite high values, suggesting that DNA tests are a useful addition to what we're doing in the lab. This is showing some of the results using the COMET test. And again, all I wanted to show you here was that the live births in the men who have low DNA damage are much higher than in those who have high DNA damage. That is not the case for ICSI, but it is most definitely the case for IVF. Again, another paper that we published recently was to look at unexplained infertility. I know many of you who are clinicians find unexplained or idiopathic infertility a real problem. You have nothing to say to the patients. The patients very often go away thinking, well, they said there was nothing wrong with us, which of course is not what you said. You said, we don't know what's wrong with you, but actually there must be something wrong, otherwise you would be getting pregnant. Something like 25 to 30% of patients, of couples, get a diagnosis of unexplained infertility, and they don't know where to go with this. Should we have IUI? Should we continue trying? Should we have IVF? What should we do? And in a study that we published a couple of years ago, we found that 80% of these men had DNA damage. Now, this has also been shown by the SCASA test, but their test has shown about 20%. But there certainly is an indication that in these men with unexplained, or couples with unexplained infertility, DNA damage is a factor. Now, if that is the case, that will change your treatment choices. So one of the things we would worry about then is if we say that a person has high DNA damage, will we then go straight to ICSI rather than going to IVF? And this is something that concerned me personally for quite a long time because it seemed to absolutely defy common sense. But what I actually think is happening is not that we are using damaged sperm, but that we're giving the egg a much better opportunity to repair the damage. Now, this was alluded to earlier, again, by Rebecca. So when we're talking about DNA damage, and also, by Victoria, when we're talking about DNA damage, we're talking about, first of all, the amount of damage there is in the sperm, and secondly, the ability of the egg to repair that damage. I would love to do some studies on this. We've tried, we haven't got funding yet, but it's so important to find out if there is a limit that the egg can actually repair a certain amount of damage per sperm. The reason why I think this is important is because there are a couple of things that are different between IVF and ICSI. The first thing is that the women who are having ICSI, maybe 30% of those women have got fertile eggs to start with, so they've probably got better repair mechanisms than women who are having to have IVF, who have not only tubal blockages but maybe problems with the quality of their eggs. The second thing is that you're putting the sperm in ICSI straight into the egg, sperm heaven. So the sperm's just in there all night instead of being in suboptimal culture media. And again, we're going to be talking about this more at this conference, about how important the quality of culture media is. And thirdly, if you think of the difference between IVF and ICSI, in IVF you've got lots of sperm with DNA damage. The reason they've DNA damage is because they're generating free radicals. You put an egg in with thousands of sperm overnight, and what does the egg do? It spends the whole night firefighting because of all these free radicals which are surrounding it. In the other scenario, you've got one sperm, one egg. You put the sperm right into the egg. As I'm saying, it's sperm heaven, but also from the point of view of the egg acts like a typical female. She spends the whole night pulling together all little broken nicks of DNA in the male, and by the morning, before you have the first cleavage stage, you've got a lot of repair done because she's able to focus on that particular issue. And I think we actually can back this up with science if you look at some of the references which I've given you there. The other thing that's really important is the fact that there is now a well-established relationship between sperm DNA damage and recurrent miscarriage. Now, this is a very novel idea, and actually I'm on a task force writing new guidelines for ESHRE at the moment about recurrent miscarriage, and this is the first time the male has ever been included in such guidelines. We've always thought it was completely a female problem. But this is quite interesting because now we're able to give a new patient pathway to couples. If they find that there's a high DNA damage and that's what's caused recurrent miscarriages, then they can think of, first of all, they've got a diagnosis, which is fantastic for them, and secondly, they've got other alternatives, because if you look at this as an infertility problem, then there are other options, for example, donor sperm or perhaps testicular sperm, and we can talk about that later if you wish. A new test has come on board. There are only a couple of publications about it at the moment. It's looking at the neutral comet assay, which looks at double-strand breaks. And of course, double-strand breaks are probably more important in terms of fertility and outcomes than single-strand breaks, because the egg can put together single-strand breaks, but can she find the double-strand breaks? That's going to be much more difficult in terms of repairing them. And of course, this is just what I was saying before, the idea that the implications of sperm DNA damage are not just the early outcomes, but they're also the health of future generations. And a couple of for the last 20 years have come out of John Aitken's group about that. So what patients would benefit from sperm DNA testing? Basically everyone, except the ones who are already going to have ICSI, because you're not going to change your treatment for them, but everybody else would be wise to have this additional test. So the one big limitation about DNA testing is you cannot use the sperm that you have used. If you do a DNA test on it, you destroy it, and therefore you can't use it clinically. Now this is where, if Raman microscopy comes in, it will be a huge step forward, because it is a non-invasive test and it will be able to measure the level of DNA damage in a particular sperm, and then as far as I know it, then you can use those sperm clinically. So that will be a major advance for us. But at the moment what we're trying to do is develop proxy tests. So a lot of people are saying, well, there's a relationship between DNA damage and these are the tests we have. We've got hyaluronic acid binding, we've got apoptotic markers, we've got surface charges, we've got IMSI, we've got DNA damage, and people are saying these all have a relationship to DNA damage. Therefore, if you do this test, of course there are limitations with DNA damage, and you can then use that sperm. At the moment, this is not really very well proven. So I know we started talking about one big study that I'm involved in at the moment is the GOLD study, which is a large study in the UK, and what we're looking at is hyaluronic acid binding in the UK, and it's between that for in the WHO recommendations. DNA. But I would agree entirely with Rebecca that one thing that semen analysis does tell us is a few things to finish the idea that sperm DNA damage actually has a relationship, but really it doesn't tell you an awful lot more than that. It has limited diagnostic value for both male infertility and hyaluronic acid binding prognostic value for ART outcomes, even the very randomized controlled trial that we're using. Again, as I say, the jury's out, but it's hopeful that this hyaluronic acid binding may be an indicator of low DNA damage, really, and we use those terms for concentration, morphology, or motility. There's very little relationship. And yes, here's the next thing I think we ought to be doing. The men who are attending for time-lapse investigations, and there's a very high overlap between the two. An imager system. On the other hand, there's very little relationship between sperm DNA as usual that we've left out semen analysis. What we're looking at eggs, we're looking at embryos, we've got no idea, because there's no point in adding an adjunct sperm of DNA testing. And the reason why people have said that it doesn't matter is because we thought the DNA integrity doesn't matter. And the only relationship that we found using the comet test was a relationship between sperm motility and DNA damage. Sperm DNA was what we would expect, because motility is a real-time indication of whether the sperm is alive or healthy. Concentration doesn't matter, and I think to some extent morphology. This is a paper that came out from Dove Carroll's group last year in America, you know, and it's showing a relationship. So we found a relationship between the number of sperm that can be detected with DNA damage between the SCASA, the tunnel, and the sperm comet. The odds ratio is about 70%, and the other which one was the better prognostic percent. So it might be, if you're going to use time-lapse fertilization in vitro test, you can see that the DNA test is much higher. The odds ratios are much higher. This again is a paper which is very much new, if semen analysis is showing that early embryo quality, if we turn to sperm DNA anomalies, we can see that they, I don't know if you're aware, that every 10 or 15 years ago there was a paper in the Lancet from poor embryo development to failure fertilization IVF, not showing that there was no relationship, that's a rather artificial sperm DNA, because the embryologist basically puts the sperm inside the egg. And people have taken that on board in ICSI, and post-implantation was published in Malformations from animal studies. Increased miscarriage is associated with high DNA damage. Many people, as you know, are very and childhood health critical, and and I think that's where we're moving to now. Because they say, again, it was very interesting what Rebecca was talking about in terms of the outcomes to different specialties are very different. And there's absolutely no doubt that there are many lifestyle choices in the 21st century. And as the number of support conceptions from ART increase around Europe, and as birth rates drop, Victoria was saying, spontaneous conceptions to be the common children who are born as a result of ART. And if that's become a larger proportion, if we were to change our lifestyle, the population, would we be able to really protect our DNA, our sperm DNA from damage, as well as just success within the lab? Again, I'm sorry to have to tell you that the jury is very much out on this too. So in terms of detecting we really don't have enough DNA studies damage, to give there are some definitive that are the most popular ones that people use. A good study which shows that which we've used in Belfast for a long time. There's the sperm chromosomal structure assay, which is the daddy of quality and also pregnancy 1980. And there's the tunnel assay, and then there's the halo test, which isn't really a DNA fragmentation test. It's more at the numbers to tell you large numbers to start. They're very small numbers. The chromatin packaging by the end is adequate or not. So again, we need to. So if we look at the tunnel. Now, we get to the point where we don't really have a clinical threshold was asking, for the tunnel. Can you antioxidants? One of the problems is that the tunnel is done very differently in every lab around the world that uses it. Now, a couple of years ago, all of us working on DNA got together in Florence and said that we would really like men to come along to infertility clinics because of the number of the centres that we have here below that we're interested in doing over-the-counter medications. First of all, to see how their local pharmacy, their local chemist, to the comet. There are also the variations both in the constituents of the antioxidants and in their concentrations within the different labs. Different combinations, different levels happen. We're now trying to very little current to evidence resurrect the idea and make it again. And I would be very keen that we would do this because we've properly organised large number of independent trials. But the question is, when are they going to be done? As I was saying, is really the opposite of all the other tests tried to get funding to do work on male infertility sperm will because you get this relaxation extremely difficult to do. So what do we do in the meantime? The proteins around there's a very good paper by John Aitken and the one here years ago talking about how we needed a halo is the one which is stress. Oxidative stress now when you get amounts is physiological. You're looking for the absence of something. It's very difficult to know how accurate that is because if there's not a little bit of something that maybe to do with your protocol to help them, but certainly you didn't actually do it properly in the proper levels. Also in terms of the actual results for the halo. The halo is very popular, but it is an increase in both fertilization and pregnancy rates. The other cells of antioxidants really have to be outsourced. There are some that we ought to avoid. For example, their routine IVF lab is not going to be able to do selenium or a comet test. But in terms of the reason I say selenium and also vitamin E is because there's a very large study in 32,000 young healthy men in America within called the SELECT study. But here's one of the biggest studies which was done, and this shows that in both the relationships and the severity of halo and either pregnancy rates or on these antioxidants for a period of a year. Here's another study which came out more recently. A second reason for not using beta-carotene is it's strongly counterindicated between DNA damage, a lung cancer with the halo and semen. But again, I wonder if, which is again what we don't really want because I'm just aware of these things, gives us confirmation and of what the other problem, and I do not wish to be sexist and secondly, but it doesn't show much of a difference between pregnancy rates. And sometimes they forget to take them and DNA damage and got pregnant. Oh golly, have a DNA damage and didn't get pregnant. My partner's going to be checking up on me. The SCASA test, as I was saying, is the daddy of them all. This was developed by Don Evenson many years ago. It's a robust test that we can actually explain to people. Many studies. There's no such thing as a free lunch, so you really need to be sure that you need antioxidants. The only way you're going to know that is if you have high levels of SCASA diagnostics, and those levels must be a result within a pretty short clinical threshold. There's no point in taking them if you don't need them. This is a possibility that you'll do harm. This is some of the results from general health. It's a waste of money, and as we know, every couple who's having fertility treatment needs all the money they have to get through it. And it's also a waste of valuable female reproductive time because if the man doesn't need antioxidants, but he's told to go off live births and a 3-month course of low DNA damage, that's not the case for ICSI. So DNA tests work well for IVF, maybe somewhere else in the waiting list they don't work so well for ICSI, and I'll talk about that in a moment. The sperm comet assay is a different number of all the other tests give you an all or nothing result. Meta-analysis about 100 cells, sperm DNA, 100 sperm through one of the things that Chris Barrett, probably well known, and you get it as I don't know, well known to many of you would say he's very DNA damage was detected in 30% of the sperm DNA test, but it wasn't detected because it's an all or nothing. It's usually a colour change. The first is to have standardised methods in the sperm comet test because what we do there is rigorous examination of your application, lysosomal membrane. lines, relax the DNA,
what tests we're going to use and how are we going to use them.
If you put it into an electric field, then depending on the big worry for us, because they will pull out into what is like a comet. So that we're absolutely sure it's called a comet. It's just like a celestial comet. And from routine labs, then you can measure the amount of damage, expensive to set up, and they're very, very time consuming. The other tests which show you the damage. A paper came out, a review article in Reproductive Biomedicine Online. Some of the criticisms of the comet have been just a couple of months ago, and I must say I was very disappointed. Number of cells, whereas the others it was just saying the same things as we've done for the last 10 years. We need more studies, an adequate number of cells, and even if you double the number of cells before we can use DNA, get the same results. Well, I am absolutely 100% behind that. In terms of establishing what are we going to do clinical thresholds, we know again we've done some work on this. This was not going to have these first of all people attending for fertility investigations, and we had fertile donors. Good cohort studies out there showing that DNA tests are useful, sort of cut-off point of about 25% are useful in 95% of batch of sperm that are produced in the next but only 7% of and so I wrote the men responding to the fertility investigations, basically saying what I just said now. So if any of you are interested in reading the facts and the opinions and a little bit more about it, and then you can the RFC have a read at that. So they're quite and this is really what I want to end with. DNA tests. We have a couple of choices. We can say to what we're doing. We've got to wait. We've got to hang on until we this is showing some of the and when is anyone using the comet test? Absolutely. And again, all I wanted to show you here was that the live birth fertility is going to be men who are useful. Low DNA tests are non-invasive. It's much higher than putting patients at high risk. High DNA damage. Certainly, we that is not the case for ICSI, but it is most definitely the case them from having something which will be of benefit. So I leave again another paper that we published recently was to look at what you think unexplained infertility. I know many of you, your clinicians, find it unexplained or idiopathic infertility a real problem. Very little, if anything, to lose. Have nothing to say to the patient. The patients very often go away thinking, well, they said there was nothing wrong with us, but of course it's not what you said. You said we don't know what's wrong with you, but actually there must be something wrong, otherwise you would be getting pregnant.
Let's open
something like 25 to 30% of patients, couples get a diagnosis of unexplained infertility, and they don't know where to go with this. Should we have IUI? Should we continue trying? Should we have IVF? What should we do? And in a study that we published a couple of years ago, we found that 80% of these men had DNA damage. Now, this has also been shown by the SCASA test, but their test has shown about 20%. But there certainly is an indication that in these men with unexplained or couples with unexplained infertility, DNA damage is a factor. Now, if that is the case, that would change your treatment choices.
And that's just
so one of the things we would worry about then is if we say that a person's high DNA damage, will we then go straight to ICSI rather than going to IVF? Should move to ICSI, but concerned me personally for quite a long time. But I completely agree with you. I think the test it should be for everyone to defy common sense. But what I actually think is happening is not that we are using damaged sperm, but that we're giving the egg a much better opportunity to repair the damage. Now, this was alluded to earlier, again, by Rebecca. So when we're talking about DNA damage, and also, sorry, by Victoria, when we're talking about DNA damage, we're talking about, first of all, the amount of damage there is in the sperm, and secondly, the ability of the egg to repair that damage. I would love to do some studies on this. We're trying, we haven't got funding yet, but it's so important to find out if there is a limit that the egg can actually repair a certain amount of damage per sperm.
Okay.
The reason why I think this is important is because there are a couple of things that are different between IVF and ICSI. The first thing is that the women who are having ICSI, maybe 30% of those women have got fertile eggs to start with, so they've probably got better repair mechanisms than women who are having to have IVF, who have not only tubal blockages but maybe problems with the quality of their eggs. The second thing is that you're putting the sperm in ICSI straight into the egg. Sperm heaven. So the sperm's just in there all night instead of being in suboptimal culture media. And again, we're going to be talking about this more at this conference, about how important the quality of culture media is. And thirdly, if you think of the difference between IVF and ICSI, in IVF you've got lots of sperm with DNA damage. The reason they've DNA damage is because they're generating free radicals. You put an egg in with thousands of sperm overnight, and what does the egg do? It spends the whole night firefighting because of all these free radicals which are surrounding it.
of the Italian
In
Society
the other
of
scenario, you've
Endocrinology,
got one sperm,
where
one egg.
we-
You put the sperm right into the egg.
somebody was
as I
not,
say, it's sperm heaven,
that
but
did
also
not
from the point
agree
of view of
with
the
this
egg.
data.
The egg
So
acts like a
the
typical
question is,
female. She
do
spends
you
the
know
whole night
of any
pulling
other
together
data,
all the little broken
or
necks
do you
of
agree on this
DNA
data
in the
for
male,
John Aiken?
and by the morning before
Shall we stay there,
you
or
have the
shall
first
we
clinic
just
stage, you've got a lot of repair
skeptic
done
about
because
it
she's able to
first?
focus on that particular
What
issue.
I was saying
and I
about
think we
sperm
actually can
motility
with
having a relationship with DNA
which
was
I've given you
simply
there.
to point out that it's the only
The other
parameter
thing
of a
that's
semen
really
analysis
important
which
is the
there is
fact
a
that there
relationship
is
with.
now a
No, I don't
well-established
think that there's a relationship
sperm
between
DNA damage
motility
and recurrent
and
miscarriage.
the
This
low
is a
DNA
very
damage. I don't
novel
think that that's
idea.
actually,
I'm on a task force,
and therefore, if we have a
new
motility
guidelines
sperm,
for
it is
ESHRE
low
at the
DNA
moment.
damage.
About recurrent
that is
miscarriage,
not
and
the
this is
case.
the first
I'm
time in the
surprised
male
that
has
that's
ever been
So you
included
think
in
about
such
motile
guidelines.
sperm
We've always
can
thought it was
have
completely a
higher
female problem.
DNA
Yes, it can.
fragmentation?
But this is
Yes,
quite
it can.
interesting because now we're
In
able
which
to give
percentage?
a new patient pathway
You don't know,
to couples.
because
If they
John
find
said
that there's a high
5%,
DNA damage, and
and
that's
he
what caused
showed,
recurrent
he's publishing
miscarriages,
Journal
then they can
Biochemistry.
think of,
So
first of all,
we
they've
can
got a
add here,
diagnosis, which is fantastic for
data
them,
from
and secondly,
Victoria's
they've got
PhD
other
thesis,
alternatives,
and
because
more or less,
if you look at this as an
the-
infertility problem, then
if you
there
use
are
UVB,
other
right,
options,
you
for
can
example,
actually,
donor sperm, or
make
perhaps
the first sperm
testicular
completely
sperm,
immobile.
and we can talk about that later if
And
you wish.
depending on what kind of UVB you use,
a
A
new,
or B,
a new
you could either make a nuclear DNA
test has come on
damage
board. There are
or
only a couple of
mitochondrial damage.
publications
So,
about it at the
that
moment. It's
shows
looking
that the
at
two
the
factors are
neutral
completely
comet
independent.
assay, which
A
looks
well
at
swimming
double
sperm
strand
doesn't
breaks. And of course,
automatically have
double
a
strand
good
breaks are
DNA,
probably more
and a bad
important in
swimming
terms
sperm
of
doesn't
fertility and
automatically
outcomes
have
than
bad DNA.
single strand
So
breaks, because
it can be
the egg can put
completely
together single strand
independent.
breaks,
It depends on
but
the
can she
testicular
find
environment
the
more or
double
less,
strand
because these two
breaks? That's going to be
processes are
much
This
more
is
difficult in
another
terms
point,
of
because
preparing them.
Yeah, but
mitochondrial is more
And of course, this is just what I was saying before, the idea that the implications of sperm DNA damage are not just the
Exactly.
early
Once the nuclear
outcomes, but
DNA
they're
is
also
done,
the health
yeah,
of
it will be
future
difficult to
generations.
So you
measure.
cannot compare the two.
And a
Right,
couple of
but I think
good
it's two
reviews have come out of John
independent
Aitken's
variables
group about that.
which don't
So
need
what
to
patients would
absolutely,
benefit from
be
sperm DNA testing?
correlated.
Basically
So I think
everyone,
Sheena is right.
except the ones who are already
A
going to
very
have
healthy
XC, because
swimming- a
you're
very
not going to
happily swimming
change
sperm is not
your
automatically
treatment
a great
for
sperm
them, but
carrying
everybody
great
else
DNA.
would be
So we must
advised to
be
have this
a
additional
little bit
test.
skeptic about the
The one
John's
big
data.
limitation about DNA testing
Okay.
is you cannot
Second
use the
point
sperm
about
that
the
you have
threshold
used.
or
If you
the
use a
cutoff
DNA test on it, you
point
destroy it,
of,
and therefore you
DNA
can't use it
damage,
clinically.
but
Now, this is
we
where random
must,
microscopy
we
comes
can,
in.
we
It will
may
be a
use
huge step
for
forward,
saying this
because
is
it is a
good, this is
non-invasive
bad.
test, and it will be
I think,
able to measure the level of
we
DNA
shouldn't,
damage in a particular sperm, and then as
we
far as I
shouldn't
know, then you
consider
can use
the
those
situation
sperm
in this way,
clinically. So
because
that
you
will be
must take in
will be a
consideration
major
the
advance for us.
oocyte
But at the moment,
quality.
what we're trying to do is develop
And,
proxy
now
tests.
we
So
don't have
a lot
enough
of people are
information.
saying,
There is
well, there's a
another
relationship
course
between
where they
DNA
are
damage
just,
and
making the
these are the
point
tests we have. We've
where
got
these
hyaluronic
studies
acid binding,
are
we've got apoptotic
according
markers,
to
we've
the
got
biomarkers
surface
of
charges, we've got
oocyte
MC, we've got biorefringence,
So I think
and people are
so
saying
far
these
we
all have a
cannot
relationship to
put a
DNA damage.
threshold.
Therefore, if you do this test,
Well,
that will give you an indication of how good the DNA is, and you can then use that sperm.
which were
At
with
the moment, this is
eggs
not really
of
very well
whatever
proven.
quality they were, but these are
One-
large numbers in these
One big
studies.
study that
and
I'm
they
involved
have
in at the
shown
moment
the
is
relationship
the
between
Select study, which
sperm
is a large
DNA
study in the UK,
damage
and what we're looking
outcomes
at
in
is
terms of
hyaluronic
fertilization,
acid binding
embryo
to
quality,
see if there is a
and
relationship
life
between
is the
that
threshold,
for ICSI
so
patients
according to
and
you.
this is where this is a
DNA.
really important point. The thresholds are
So I'm
different
finding it
for
hard to see
DNA
these because
tests.
they're so small.
Now, something else
a few things in, just in, to
Tanya,
finish
let's
are
get
the
Tanya.
idea
I don't
that
know, but
sperm
Tanya, that's
DNA
the one I was
damage
saying that
actually
as
has a
far as I
relationship
understand,
with
there's not
the health of
a clinical threshold at the
outcome,
moment,
which
Well,
is
no, I haven't got quite
robust
yet.
enough
So
to
this
be
is the paper which
the
is talking
same
about
for
hyaluronic
every
acid binding
person who's
and
using
it's
it.
some of
It
the-
is
the
there is a
foundational work
threshold
which
for the
has led to
SCASA,
this randomised
30%,
controlled trial that
which
we're
means
using.
30%
Again, as I say, the
have
jury's out,
damage,
but it's
and
hopeful
70%
that
don't.
this
And that
hyaluronic
hyaluronic
acid
acid binding may be
Now
an
we,
indicator
and with
of
us,
low
it's
DNA damage, and we've
25%, but
been
it's
using sperms
20%
for
25% damage per
So that's the
sperm,
study that I'm
not-
talking about. If you
So we
if you
get
want to
damage in
look
every
further
sperm
at it.
because our test
Yes,
is
now
very
here's the
sensitive.
next thing I
But
think we ought to be
it's
doing.
an
As you
average,
know,
a mean of
time-lapse imaging
25%
is the
per
age.
sperm.
Everyone
It's
has
the cutoff
got
that we have.
some sort of
Last
an
point is
imager system
about
in their
treating
ART clinic
patient,
now. And the one thing,
with,
again, as usual, that we've left out
antioxidant
is the sperm.
As
When
you
we're looking
know,
at
this
its eggs,
problem
we're looking
started
at
in
embryos,
Italy
we've
because
got
we
no
had a
idea if
factory in
there's a
Italy
relationship
which
between
made
the sperm
carnitine,
and the eggs.
which
And the reason
was,
why people have said
so
that it doesn't
several
matter is
times
because
was
we've
done
thought
that
that
way.
DNA
I think
integrity
that,
doesn't matter until you
so
get
far, we
much
cannot
farther
say
on
treat
than an
or
early
not
embryo.
treat.
Again, that is not the case.
Sometime,
There are papers
we
that have
are
come out to
very
show that DNA, sperm
desperate
DNA,
with patients.
affects
So
fertilization
we
and right through
give
from
for
early embryo
desperation,
cleavage. So
treat
it is
with
something that we could
antioxidant for
include in
desperation,
time-lapse
as we treat
imaging
this
as well, and I
patient
think
when
we
he
ought to.
have
This is a paper
continuous
that came out from Doug
prostatitis,
Carroll's group
urethritis,
last year in
pelvic
America,
inflammation,
and it's
we
showing
treat
a
with
relationship
antibiotic,
between
but
the
it's
number of
question
sperm
of
that can be
desperation, not
detected with
question
DNA
of
damage between the
treating
scaza, the tunnel, and the sperm
treating on
comet.
the
You can see with the comet
basis
it's about
of medicine
70%, and the
evidence.
other two are about
So do you agree on
15%.
that?
So it might
Yes,
be
I do.
good
My
to use
attitude.
time-lapse
I do agree,
imaging
but I
with a
certainly
test.
think that you need to
The
do a
comet
test
test
to
would
see
be the
that the
one to
person
use
has
there.
high oxidative stress
This again
before
is a
you treat
paper which
at
is
all.
very
And then
much
what treatment you use,
new,
again,
novel,
we
and
don't
exciting,
really know the
showing
very
that
best
early
one
embryo
yet.
quality is dependent on sperm DNA quality.
Jens
I don't know if you're
thank you
aware
for your
that 10
presentation.
or 15 years ago there was a
It's
paper in the
about,
Lancet
also about
by
treatment
Peter
with
Brody
antioxidants.
in a London clinic showing
there are a
that
lot
there
of
was no
specialists
relationship
working
between
with this,
sperm DNA
things,
and early embryo
maybe not so much in
quality.
the
And people
andrology,
have taken
but
that on board.
also in
Obviously, it was such a good journal it was
other
published
audience.
in. But new data is now
as I hear
making us think
those
quite
people
differently
always
about this.
distinguish between
Many people, as you know, are
direct
very
acting and indirect
critical and
acting,
unsympathetic to
antioxidants.
infertile couples because they say
So,
you brought it on yourself.
for example,
it's all your own
the
fault. Either you
vitamins,
waited too long to have
for
children,
example,
or it's
C
something to do with your
vitamins.
lifestyle.
It is,
And there's absolutely no doubt that there are many
it is
lifestyle
very
choices in the
short-lived
21st century which do not support good
it burns
fertility.
out very fast
But
after
to get
giving
back to
it,
what Victoria was saying,
and it is,
oxidative stress seems to be
in contrast
the common
to some
factor,
of those
the big culprit.
plant
And if that's the case, then if we were to change our lifestyle, would we be able to protect our DNA, our sperm DNA from damage? And again, I'm sorry to have to tell you that the jury is very much out on this too.
So
We really don't have enough studies to give some definitive information. Now here's one study, a good study, which shows that there is a relationship between oral antioxidants and both sperm quality and also pregnancy rates, and that's a start.
And we have to be sure that we are not.
The second one is a Cochrane review, but if you look at that, you can see that there are numbers in it, although there are large numbers to start.
I
There are
agree
very
entirely.
small
Thank you.
numbers.
That's a very important point.
By
I
the
think
end,
as
as well as
the
the
action,
so again,
we also
need
have to
bear in mind
have
that
more
vitamin
work
C,
done.
for example,
Now, we
is
get to the point
hydrophilic,
where,
so it's in where Professor Schlatt was asking, can you whereas vitamin E is hydrophobic, give people
so it is
antioxidants, and do the
inclined to
antioxidants
stay
stay in
in
the
the
body
body
for
for
longer,
longer,
or might they become
and so
pro-oxidants?
they have a difference
And I think
in
this
that
is a
respect
very
as well.
important point.
In terms of
we
vitamin C
shouldn't
and vitamin
be
E, they're
prescribing
scavengers,
antioxidants
so
they are picking up
free
onto
radicals
infertility
and
clinics
neutralising
because
them.
of number of
Straight away,
factors
there are
that we
other
have here
things
below,
like zinc
and
and selenium,
if people take
which again were
over-the-counter
alluded to earlier on,
medications from
which have different actions
their local
in
pharmacy or
terms of
local
what they might
chemist,
do to protect or
there
not
are all
protect
sorts of
DNA.
variations.
So
both
yes, you're
in
absolutely right. It
constituents
needs
of
to
the
be done.
antioxidants
I'm
and in their
not
concentrations.
particularly
There are different
optimistic, but
combinations,
I'm going to come
different
back
levels.
next year and tell you that it has been done.
There's
Or
very
the
little
following year.
current evidence that would make us
think I heard
recommend
you
such
say
things. So we
that,
do
you were
need
gonna comment about
properly
testicular
organised,
sperm.
large number,
Yes.
independent
Could you do that?
trials.
I could.
But
I
the
could.
question is, when are they going to be done? When are we going to have funding? And any
places
of you
which
in
is
this
a
room who have tried
physiological
to
place
get
for
funding
sperm
to
to
do
be,
work on male
but a very
infertility
dangerous place
will
for sperm to be
empathise
is the
with me that
epididymis.
It's extremely difficult
And
to do.
although
So what
we-
do
of
we
course
do
we have
in
to
the
do
meantime?
the
Sperm has to move through the epididymis to
The-
acquire
there's a very good
motility.
paper by
And,
John Aitken,
the disulfide
a couple of
bridges,
years
which
ago
give it
talking
a lot more
about
compaction
how
of
we
the DNA
needed
to
a
protect
little
the
bit of
DNA.
oxidative stress.
It's
It also
oxidative stress in
stresses where
small
there's
amounts,
obstruction,
physiological
inflammation,
and actually there are lots of sperm
leukocytes,
functions
old
which won't,
sperm, if the man
won't
hasn't ejaculated
happen
for a
if
while,
there's not
all
a
sorts
little bit
of
of
enemies
free radical
prowling
activity
around
there
within
to
the
help them.
epididymis.
But certainly there's no
And
doubt, and there are a
if
number
in
of
the proper,
papers
from our group and from
levels
other
and
groups
the
that
proper
show
constituents,
if
the
you
proper
have
cofactors,
ejaculated
there
sperm
is an
with
increase
high
in both
DNA damage,
fertilization and pregnancy rates
if you go to
with
the
the use of
testis,
antioxidants
of the same man,
there are
you
some
can
that we
get,
ought to avoid. For
testicular
example,
sperm,
there,
which are much lower
large
damage.
doses of vitamin C
And
and
we
selenium
actually had
our first
bad news.
public. The reason I say
common
selenium and
baby,
also vitamin
a couple
E
of
is
weeks
because
ago,
there's a
people
very
obviously
large
don't like
study
to
talk
talk
about this sort of thing.
Young,
But this just to
healthy
give you
men
an
in
America was called the
of a
Select
case
study.
This was a
And
couple
what they
who
found
had
there was actually
high
an increase
DNA damage
in
They'd
both
had,
the incidence and the
ejaculated
severity of
sperm, they'd
prostate
had
cancer
several
to
times,
people who'd
no
been
success.
on
They
these
changed their
antioxidants
lifestyle
for a period of
for
a year.
confining factors to the
A second
lifestyle.
reason for
And
not
also
using beta-carotene is it's strongly counterindicated.
It had 50%,
a lung
56%
cancer risk
damage in the ejaculated
But
sperm,
again, I wonder if
24% damage
fertility
in
clinics
the
are aware of these things, and they have a healthy baby boy. And I do not wish to be sexist here, but men are awfully good at taking medications, and sometimes they forget to take them, and then they think, well, at the weekend, oh golly, haven't taken them all week. Another option, my partner's going to be go checking up on me, and they take a large sperm from that man, and that's really not a good idea. Get a sample which has lower. I think we need to do proper studies and get proper results that we can actually explain to people that there's no such thing as a free lunch. So you really need to be sure that you need antioxidants. The only way you're going to know that is if you have high levels of oxidant stress, and those levels must be above a robust clinical threshold. There's no point in taking them if you don't need them. There's a possibility that you'll do harm. There's a possibility you might harm your general health. It's a waste of money, and as we know, every couple who's having fertility treatment needs all the money they have to get through it. And it's also a waste of valuable female reproductive time, because if the man doesn't need antioxidants but he's told to go off and take a 3-month course of antioxidants and come back, been shown then that's 3 months older that his partner is, and maybe somewhere else in the waiting list for DNA damage, so that's not a good idea either. So those are the tests which have been an indication. A number of studies, a number of oxidant meta-analysis about sperm DNA. One of the things that Chris Barrett, probably well known,
thank you very much for your talk.
well known to many of you, would say he's very
to the testicular sperm.
Sperm DNA testing, but he thinks that there are things that we need to do before they become routine. The first is to have standardized methods. We talked about that a moment ago. A rigorous examination of their application. No, I think it would be a very invasive thing. What tests are we going to use, and how are we going to use them? Most of the studies that have been published in Greco that is a big worry for us, because I think most of these tests are going to be outsourced, so that we're absolutely sure of quality control. And I don't think there's something because I don't think routine labs are going to want to take on board, because but if you've had repeated failures, and very, very time-consuming clinical solution is for the man to have donor sperm. Then a review article in Reproductive Biomedicine Online, some of you may have seen it, try with just a couple of months ago. And I must say I was very disappointed
instead of
with it, because it was just saying the same things as we've heard for the last 10 years. Oh, we need more studies, we need randomized control trials, we need more evidence before we can use DNA tests. Well, I am absolutely 100% behind that. That's been done, I think, to show these DNA damage levels have been done on the austerity that we're in at the moment. We know we're not going to have WHO recommendations. There's an absolute plethora of between 2 and 5 days cohort studies out there showing I haven't seen any publications that have shown that DNA and quality antioxidants are useful in protecting the next batch of sperm that are produced in the next 2 months. And so I wrote a response to this article. Yes, I understand what I've just said now. So if any of you are interested in reading the facts and the opinions and a little bit more about it, then you can have a read at that.
You made a comment
and this is really what I want to end with.
Culture conditions.
We have a couple of choices. We can say we've got to wait, we've got to hang on until we are absolutely sure. And when is anyone ever absolutely sure that a test in infertility is going to be, if that's what people are going to do. DNA tests are non-invasive. It's not as if the papers patients at high risk, where they found that there actually was have you looked at that paper preventing them from having something, which will that's fine, because there are 2 or 3. So I leave that. But actually, I think this is something that's going to be discussed your own conscience as to what you think about we ought to do. Culture conditions. Yes, in my opinion, quite sure we've much to gain. That is a possibility. Very little, if anything. There are people who are very pro that paper, and there are people who are very much against it. But it's just the idea that you can never have as good a culture condition as the ulemma.
Let's open for discussion.
So that might be the best place for
Thank you very
to
much
be
for
if it's
this
got damage.
outstanding presentation. We usually routinely do the DNA and the decantation test.
Sheena, I think we're at the stage you would agree where we really need gradient of principal components analysis.
In Paris.
No way we need to put all these factors together, compensate for age. For example, in this crazy animal I showed this morning, we have 80% on an average basis, 80% fragmentation. We have 24 pups every time.
We do the test and we try to improve
so there
the
is
DNA
a female
before doing the
species
if we can,
to fix
by
it.
varicocele
It must
treatment
be,
or any
I'm sure, because there's
antioxidant
just a
that
few
we
sperm
can.
that are normal.
And that's just
So
the
the moral of the
difference
story
with
is,
your...
Well, I'm delighted to hear you say that. I wasn't. I just didn't want to go over the top.
Influence the ability of
because I think I've IVF should move to ICSI, but if you're
and
already
there are
doing ICSI,
multiple
well,
factors.
I
And what I'm
completely agree
suggesting,
with
and
you.
a
I
lot of
think the
people have
test
said
should
this
be for
about semen
everyone, so
analysis.
thank you for your
I
support.
think one of the reasons why it's not working well and why it's not very good, and I agree with
for
you,
your presentation.
in IVF studies,
You were
is that
running
we
very
now need to
fast.
put
So
Yes,
a
I'm
lot of
I'm
these
sorry,
animals
I'm
together,
sorry about that.
typically as
to get your
biplots,
point, but anyway,
as biplots, I mean,
your
in
slide,
principal
so I can
component
comment
analysis,
that.
and then
First
show
point.
which are really the factors
Can we
that relate. Don't you
come
agree?
out from this room?
Yes, I do agree. I think one thing that
points,
possibly
according to the literature,
you're leading to is the idea that fidelity is not a good thing for a female, which is really very
You
surprising.
said that as
Because
long
if
as,
she is within a faithful couple, then she's going to have poorer sperm and she's going to have more work to
we are
do
sure
to
that
actually create
there
a
is
healthy
no
baby.
DNA
that's just
damage.
a bit facetious.
Okay,
Can't.
so do we agree
think,
all on this? Because there
taking
is
up on this,
only
I
one
think you
paper
hit
by
the
John
critical part about all
which
of this.
showed
All
that
of this is very
when
good, but it's
he
association.
measured
It's relationship.
contemporarily
Until you get to the
live
stage where you
sperm,
come up not only
DNA
with principal component
fragmentation,
analysis,
and
but you come up with causation.
adducts, 8 adducts. And they
This
show that
is very
as long
nice.
as you get a live
good,
sperm, the
but it doesn't tell us the
probability of
fundamentals.
having DNA
25%
fragmentation
of the
is only
threshold,
5%.
that's 25% of sperm.
Who is this paper by?
Yeah,
Right.
yeah,
That
yeah.
means you
yeah.
have
Who's-
a
who's-
1 in 4
only
chance
5%
that you're
of
not
the
going
live
to.
sperm
You have a
may
3
have,
in 4
according to
chance
his
of
experience,
hitting a
may
correct
have
sperm.
DNA fragmentation.
Yes.
So
Who
it's
is the
very
author?
low.
For the
It's quite
analysis to
low.
be done, it
But
can't
it's
be a
still there.
meta-analysis.
I mean,
You're looking at
you have any
what a
experience
few
because
studies
this is
have looked
the
at and
only
come up with
paper
their
that
results,
I
and then you
find
say
in
if their results are
literature.
correct,
Recently,
therefore
we had
overall the
just
results
last
are
week
correct.
we had a meeting in
What you did,
Taormina
what are
of
the
the Italian
chances
Society
by
of
luck
Endocrinology,
of being
where
able to come
we
up with these results?
somebody
This is
was
why
not
it's vital
that
that this
did
thing
not
that
agree
started in
with this
Florence
data. So
has to be
the
done.
question is, do you know
The
of any
argument
other
of we have
data,
nothing to
or do
lose
you agree on this
is,
data for John A?
personally, flippant.
Shall we stay there, or
Because
shall we
apart
just
from
be
providing a
skeptical about
diagnosis,
it first?
we can't provide them with the therapy.
What I was saying
we can't
about
provide them with the
sperm
means of being able to get
motility
home,
having a
and all
relationship
we are
with
doing
DNA was
is
simply to point
providing
out that
a
it's the
smokescreen.
only parameter of a semen
When
analysis
the
which
antioxidant
there is a
stuff
relationship
works,
with.
if it works,
No, I don't think that there's a
great.
relationship between motility
Great.
and
But to
low
come up to
DNA
someone
damage. I
and
don't
say,
think
you
that
know
that's
what,
a,
we found a
a
test and you've
factor
got
that we can
50%
take,
chance,
and therefore if we
go
have a
and have
motile
major
sperm, it is low
surgery.
DNA damage. That is,
Go and
no,
have a
that is not the
testicular
case.
biopsy.
I'm surprised if that's what...
So you
that's
think
very
that
foolhardy.
motile sperm
Can
can
I
have
just go back to the
higher
point you're making?
DNA
I think you
fragmentation?
misunderstood.
Yes,
The
it can.
25%?
You know,
You're saying
which
the 25%
percentage?
threshold meant that a quarter of the
You
sperm
don't
were
know,
damaged? Is that what you
because
said?
John said
According to your-
5%.
Let's go
and
back
he
to the
showed,
first
he's
Luke
publishing
Simon
Journal
paper.
Biochemistry.
You've
Yeah.
got
Well,
less than
looking at your,
40%, correct?
data from Victoria's
then you
PhD
swap,
thesis,
and you go
more
to
or
less than 25%.
that
So you're saying
if you use
in one,
UVB, right,
a percentage
you can
of the
actually
population. In the
make
other,
the sperm
you're
completely
stating what
immobile.
you perceive to be
And
the
depending on what
extent of
kind of
damage within a single
UV you
sperm,
use,
correct?
A or B, you can either make a nuclear DNA
No,
damage
not
or a
correct.
mitochondrial damage.
In terms
So
of the 25%,
that shows
it's,
that the two
that
factors
is
are completely
the
independent.
level of the
A well-swimming
damage,
sperm
the
doesn't
mean
automatically
damage
have a
in the
good
sperm.
DNA.
In how many sperm?
A bad swimming sperm
In
doesn't
all the sperm that were
automatically have
measured.
bad
In all of
DNA.
them. So
it
every
can
single
be
sperm has got
completely
25%
independent. It
damage.
depends on the
That's-
testicular
that's the
environment
same.
more or less,
It's the
because
same
these two
in both of them.
processes
It's not-
are
But this is
quite
another
Well, it's
point,
not,
because
because
Yeah,
you've
but
quoted
mitochondrial
40%
is
on Luke
more
Simon's
sensitive
No, no,
to
no, no.
Yes, yes.
oxidative
Look up your own
damage
slide.
than
No, hang on,
nuclear
I know
DNA.
exactly
exactly.
what's
Once the
in
nuclear
that.
DNA is
25%
it will
is
be
the
difficult
cutoff
to
So you
point
cannot compare the
for
two.
infertility.
But I think
In
it's-
that what
it's
I was
two
saying
independent
was that this was a cutoff. If you had more than 25% damage, then you were within the
So I think
infertile
she
range.
is right.
In
In
terms of
a very healthy swimming, a very happily
yes, the
swimming
average
sperm
amount
is not automatically
per
a
sperm.
great
They're all
sperm
per
carrying
sperm.
great DNA.
And
So we must
secondly,
be
it was whether or
a
not
little
there would be
bit
successful
skeptical
with
about the
IVF,
John's
and that was where the
data.
25 to
Okay.
50%
The second
came
point
between
about the
whether you use
threshold
IVF or
of
whether you
the
use
cutoff
ICSI. So that was the
point
prognostic
of,
aspect
DNA
of the
damage,
test,
but
as opposed to
we
the diagnostic
we
aspect.
we may
It
use
still doesn't answer
for
the question.
saying this is a good, this is bad. I think
we really treating you hard.
we shouldn't
I screened
we
through all
shouldn't
the abstracts
consider
with the
the situation in this
situation.
way, because
There
you
were about
must
300. I
take
think
in
at least half of them get
consideration
was
the
oxidative damage.
oocyte
And
quality.
I perfectly agree with you
And
that
now we don't have
let's
enough
say
information.
many of
There is
these
another course where they are just
scientific works
making
were
the point
observations.
where these studies
on very
are
limited number of
recording the
patients.
biomarkers of
So
oocyte quality.
we will not get
Yes,
So I
I
think
think
that
that's
so far
important.
we cannot
all
put
these
a threshold.
So you made a few
Well, I
very
think we
important
because the
say,
thresholds
look,
that we have
let's
here
get
are
some more
the
data.
ones which
But
were
there's a lot of
with
people in the room which go
eggs
back
of
home
whatever
tomorrow.
quality they were, but
But
there's
this is
in
correlates.
large numbers
And
in these
they may be
studies,
able
and
to
they
give
have shown
some
the
good
relationship between sperm
Get another
DNA
150
damage
next year,
and
we say, okay,
outcomes
there's
in
more
terms of
to that.
fertilization, embryo
But you made a
quality,
few
and
suggestions
life
what we
weight.
can do. So
threshold, though. So
Well,
What more that
this
we
is
get
where this
better
is a really
evidence
important
in a
point.
year or two
The
without
thresholds
huge
are
studies
different
which
for
would cost a
DNA
huge
tests.
amount of
Now,
money. They
something
can't do
else
that.
where
Most
we've got
people believe
completely
you would like to
confused.
add
let's
data,
get
but they
the
can't do
candidate.
it. So
No,
what
Tom,
would
that's
be
what
the
I'm
data?
saying.
Do
That as
we
far
have
as I
to
understand, there's no,
example to
there's not
correlates,
a threshold at the moment, which is
chips to do it
robust
ourselves,
enough to be the same for every
collaboration with
person
other
who's
people
using
which
it.
can help
There
us.
is a threshold for the SCASA,
Some of
which is
these
30%,
This is, I
which
think, a
means
very
30% of the
important
sperm
message
have
to
damage
people
and
that
70%
eventually
don't.
you do
That is
nothing,
the cutoff.
then you can also say that
Now and with us, it's 25%, but it's 25% damage per sperm, not. We get damage in every sperm because our test is very sensitive. Small studies, actually, an average, a mean of 25% per sperm. Sorry, is the cutoff that we have. If we do a lot of small studies, I don't think I have a message to individual labs that this is what you can do in the next year, because I don't think the information's there. I certainly agree with Con that we
As
need
you know,
to
this
have
problem
I
started
would
in
agree,
Italy
and
because
especially
we
to
had
bring-
a factory in Italy which made carnitin, which was so several trials was done that way. I think that so far we cannot say treat or not treat. Sometimes we are very desperate with the patient, so we give for desperation, treat with antioxidant for desperation, as we treat this patient when they have continuous prostatitis, urethritis, pelvic inflammation, and we treat with antibiotics. But it's question of desperation, not question of
knowledge.
treating on the basis of medicine evidence. So do you agree on that?
Yes, I
on
do.
my attitude?
I do agree, but I certainly think that you need to do a test to see that the person has high oxidative stress before you treat at all. And then what treatment you use, again, we don't really know the very best one yet.
Jens Feder, thank you for your presentation. It's about also about treatment with antioxidants. There are a lot of specialists working with these things, maybe not so much in the andrology, but also in other audience. As I hear it, those people always distinguish between direct acting and indirect acting antioxidants. For example, the vitamins, for example, C vitamins, it is
Scavengers.
It is very short-lived, and it burns out very fast after giving it, and it is in contrast to some of those plant extracts with pomegranate and what has been published in small studies with a modest but significant effect on semen quality, at least. So I think we have to distinguish between direct acting and indirect acting antioxidants in the future, and of course we need some large studies, as you said, and we have to be sure that we are not exposing our patients for damage. Yeah.
Yes, I agree entirely, and thank you. That's a very important point. I think as well as the action, we also have to bear in mind that vitamin C, for example, is hydrophilic, so it's in it's in watery fluids, whereas vitamin E is hydrophobic, so it is inclined to stay in the body for longer, and so they have a difference in that respect as well. In terms of vitamin C and vitamin E, they're scavengers, so they are picking up free radicals and neutralizing them straight away. There are other things like zinc and selenium, which again were alluded to earlier on, which have different actions in terms of what they might do to protect or not protect DNA. So yes, you're absolutely right. It needs to be done. I'm not particularly optimistic that I'm going to come back next year and tell you that it has been done, or the following year.
I think I heard you say that you were going to comment about testicular sperm.
Yes.
Could you do that?
I could. One of the places which is a physiological place for sperm to be, but a very dangerous place for sperm to be, is the epididymis. And although of course, the sperm has to move through the epididymis to acquire motility and to gain the disulfide bridges, which give it a lot more compaction of the DNA to protect the DNA. It's also a place where there's obstruction, inflammation, leukocytes, old sperm if the man hasn't ejaculated for a while, all sorts of enemies prowling around within the epididymis. And there's no doubt, and there are a number of papers from our group and from other groups that show if you have ejaculated sperm with high DNA damage, if you go to the testis of the same man, you can get testicular sperm which have much lower damage. And we actually had our first public comet baby a couple of weeks ago, because people obviously don't like to talk about this sort of thing. But this, just to give you an indication of a case study, this was a couple who had high DNA damage. They'd had ejaculated sperm, they'd had ICSI several times, no success. They changed their lifestyle, so there are two confounding factors here. They changed their lifestyle and also had ICSI with testicular sperm. They'd had 50% or 56% damage in the ejaculated sperm. They had 24% damage in the testicular sperm, and they have a healthy baby boy who they had all over the papers a couple of weeks ago. So it appears that if you have failed ICSI cycles with ejaculated sperm, that another option is to go to the testicular sperm from that man and see if you can get a sample which has lower level of DNA damage.
I have another question. You said in your presentation that it is not possible to treat all the patients with antioxidant, and before we have to test. In your opinion, what would be the best test to identify the damage induced by ROS? Because sperm DNA damage is a probable consequences, but not only, because it's also maybe due to a spermatogenesis defect.
Yeah. Well, the two tests that have been shown to have an oxidative cause for DNA damage are the SCASA and the COMET. So those are the tests which have an indication that the person has high levels of oxidative stress causing DNA damage.
Hi, Sheena. Thank you very much for your talk. Going back to the testicular sperm, if we have a high DNA fragmentation at the ejaculated sperm, do we assume that testicular sperm is better, or do we have to check that also before going on to ICSI?
No, I think that would be a very invasive thing to do. And I think most of the studies that have been published, and Greco and Tesserick are the people who've published on this, although there are small numbers, it is men who have had repeated failures with ICSI, because I don't think you want to go for testicular biopsy at the beginning. But if you've had repeated failures and the only clinical solution is for the man to have donor sperm, then in that case, I think he's quite keen to have one last try with testicular sperm and ICSI.
How about if instead of getting into the testes, have ejaculates many times and use sperm from the last ejaculate that had stayed for a very short period in the epididymis? That's very cheap and very easy to do, I guess.
All the work that's been done, I think, to show these DNA damage levels have been done on men who have produced semen samples according to WHO recommendations, so 2 days abstinence, between 2 and 5 days. I haven't seen any publications that have shown that DNA quality improves with daily ejaculates. But if that were the case, well, that would be very interesting.
In the sense that it doesn't stain the epididymis long.
Yes,
that's what I was wondering.
I understand your theory. Yeah.
Okay, thank you.
Makes sense.
Hi. I just you made a comment about suboptimal culture conditions, and that's why we should go to ICSI.
Yes.
Would it not? I'm not sure what you mean by suboptimal culture conditions, but would it not be better to improve conditions, maybe stick with IVF?
Well, yeah, it would, if that's what people are going to do. But I was thinking of the papers by Dumoulin, where they'd found that there actually was a different.
Have you looked at that paper closely? Because I think it's quite flawed.
Okay, that's fine, because there are 2 or 3 of those. But I think this is something that's going to be discussed here in ESHRA about culture conditions. And yes, I'm quite sure that is a possibility. There are people who are very pro that paper, and there are people who are very much against it. But it's just the idea that you can never have as good a culture condition as the ulema. So that might be the best place for the sperm to be if it's got damage.
Okay.
Sheena, I think we're at the stage you will agree where we really need a great deal of principal component analysis. You know, where we need to put all these factors together, compensate for age. For example, in this crazy animal I showed this morning, we have 80% on an average basis, 80% fragmentation. We have 24 pups every time. You know, so there is a female species with an ability to fix up. It must be, I'm sure, because there's just too few sperm that are normal. So the moral of the story is, I'm sure age and all those factors influence the ability of an oocyte to fix an egg. And there are multiple factors, and what I'm suggesting, and a lot of people have said this about semen analysis, I think one of the reasons why it's not working well and why it's not very good, and I agree with you in IVF studies, is that we now need to put a lot of these parameters together, typically as bioplots, as biplots, I mean, in principal component analysis, and then show which are really the factors that relate. Don't you agree?
Yes, I do agree. I think one thing that possibly you're leading to is the idea that fidelity is not a good thing for the female, which is really very surprising, because if she is within a faithful couple, then she's going to have poorer sperm and she's going to have more work to do to actually create a healthy baby. But that's just being a bit facetious. Con.
I think, taking up on this, I think you hit the critical part about all of this. All of this is very good, but it's association. It's relationship. Until you get to the stage where you come up not only with principal component analysis, but you come up with causation, this is very nice, it's good, but it doesn't tell us the fundamentals. 25% of a threshold, that's 25% of sperm. Right, that means you have a 1 in 4 chance that you're not going to do it, but you have a 3 in 4 chance of hitting a correct sperm. So, for the analysis to be done, it can't be a meta-analysis. You're looking at what a few studies have looked at and come up with their results, and then you say, if their results are correct, therefore overall the results are correct. What you need, what are the chances by luck of being able to come up with these results? This is why it's vital that this thing that started in Florence has to be done. The argument of we have nothing to lose is personally flippant, because apart from providing a diagnosis, we can't provide them with the therapy, we can't provide them with the means of being able to get on, and all we are doing is providing a smokescreen. When the antioxidant stuff works, if it works, great. Great. But to come up to someone and say, you know what, we found a test and you've got 50% chance, go and have major surgery. Go and have a testicular biopsy. I think that's very foolhardy.
Can I just go back to the point you're making? I think you misunderstood the 25%. Were you saying that 25% threshold meant that a quarter of the sperm were damaged? Is that what you said?
According to your, let's go back to the first Luke Simon paper. You've got less than 40%, correct? Now, then you swap and you go to less than 25%. So you're saying in one, a percentage of the population. In the other, you are stating what you perceive to be the extent of damage within a single sperm, correct?
No, not correct. In terms of the 25%, that is the level of the damage, the mean damage in the sperm.
In how many sperm?
In all the sperm that were measured.
In all of them. So every single sperm has got 25% damage.
Correct. That's the same. It's the same in both of them. It's not different.
Well, it's not, because you've quoted 40% in Luke Simon's paper.
No.
Yes. Look up your own slide.
No, hang on, Con. I know exactly what's in my slides. 25% is the cutoff point for infertility. In that, what I was saying was this was a cutoff. If you had more than 25% damage, then you were within the infertile range.
In terms of the
yes, the average amount per sperm. They're all per sperm. And secondly, it was whether or not you would be successful with IVF, and that was where the 25 to 50% came, between whether you would use IVF or whether you would use ICSI. So that was the prognostic aspect of the test, as opposed to the diagnostic aspect.
Mm-hmm. It still doesn't answer the question.
Perhaps I can raise another question. We're really treating you hard here, Sheena. I screened through all the abstracts from the andrology submissions to ESHRE. There were about 300. I think at least half of them dealt with oxidative damage.
Yeah.
And I perfectly agree with you that, let's say, many of these scientific works were observations on very limited number of sperm, very limited of patients. So we will not get really good evidence from all these attempts. So you made a few very important marks in that you say, look, let's get some more data out. But there's a lot of people in the room which go back home tomorrow into the andrology labs, and they may be able to do some good data. That not yet another 150 abstracts next year, we will say, okay, they're not really valid. But you made a few suggestions what they can do. So what tomorrow that we get better evidence in a year or two without huge studies, which would cost a huge amount of money? We can't do that. Most of the people in the room here would like to add data, but they can't do it. So what would be good data? Do we have to send them the samples to SCASA labs? Do we buy Halo chips to do it ourselves? Do we implement a collaboration with another group which can help us to do some of these techniques? This is, I think, a very important message today, that eventually we can do nothing, but then you can also say that to get an improvement of all these poor data situation which we have.
Yeah. Well, thank you. I think you're saying a couple of things. One is that a whole lot more small studies actually will just end up with what we've got at the moment. Sorry. So if we do a lot of small studies, I don't think I have a message to individual labs that this is what you can do in the next year, because I don't think the information's there. I certainly agree with Con that we need to have...
I would agree, and especially to bring